Thanks, Mr. Katz. My name is Michael Schulder. I've been an attending neurosurgeon for 32 years. Currently, and for the last 13 years, I've been professor and vice chairman and neurosurgical residency program director at the Zucker School of Medicine at Hofstra Northwell. I have a bunch of other titles, but what's relevant here is I'm the director of the Brain Tumor Center at the Northwell Neuroscience Institute. And welcome everybody. I think your interest is wonderful and it's exciting for me to speak to you today. I understand you've heard lectures from Dr. Bukvar about management of patients with gliomas and Dr. Silva about patients with pituitary tumors. And today I'd like to speak to you about patients with metastatic brain tumors and why that is important. And why am I not advancing now? Okay. All right, I'll use the arrows. There we go. So just a little overview of the Northwell Health System. What's relevant is that North Shore University Hospital, where our residency program is centered, is here in Nassau County, just outside of the Queens-Nassau County border. This is New York City here, Brooklyn, Queens, Manhattan, the Bronx, and Staten Island, for those who are not familiar with it. Lenox Hill, which you know about from Dr. Bukvar, of course, is over here. Dr. Silva works up here in Phelps. And then there are other hospitals in the system throughout the New York area. So 25 hospitals in all, and our Stereotactic radiosurgery center is in an outpatient facility near North Shore University Hospital. LIJ Medical Center is right near that outpatient facility. That's another large hospital where our residents go. This is the facade of North Shore. Our research institute, the Feinstein Institute, is across the street from here. And the well-known Cold Spring Harbor Lab is about 25 minutes east on the North Shore, and that's a research affiliate of ours. So what is a metastatic tumor? So metastasis is a pathogenic agent, and metastasis is the process of a pathogenic agent spread from an initial site to another site in the body. It doesn't have to refer to a tumor, although that's what it most commonly does mean. It's a malignant tumor that spreads to another site in the body. So a metastatic tumor forms a secondary tumor from a primary cancer. Why does this matter? I'm not saying that patients with gliomas or pituitary tumors are somehow less deserving of care, and I treat those patients as well, believe me. But the number of people who have or are at risk for getting brain metastases is much greater than those with primary brain tumors. It's as many as 400,000 people a year in the United States, 10 times as many as all patients with primary brain tumors. And about 1/3 of people who get cancer will get a brain metastasis. And the number of people who get cancer will increase as overall life expectancy increases, which it has and it will continue to do after the COVID-19 crisis passes, as it will. So what do we know about metastatic brain tumors? They most commonly spread through the bloodstream, and the incidence of where the tumors end up follows where blood flow goes to the brain. So most commonly they're in the cerebral hemispheres. About 1/6 go to the cerebellum, and about 1/20 go to the brainstem. And that simply reflects the percentage of blood flow to those different areas of the brain. And different histologies, different types of primary cancers have a greater or a lesser propensity to metastasize to the brain. So people who have lung, breast, renal, which is kidney cancer, or melanoma, those are the most common types of metastatic tumors that we see in the brain. So if you go back a few decades, not all that long ago, in fact, past the point where I finished my training, the overall survival expectation for patients with a metastatic brain tumor was dismal. We knew that without treatment, it was about a month. If you gave the patient steroids to decrease brain edema, or what we call in lay terms, brain swelling, maybe 2 months. And then if you added radiation to the whole brain, which is what it sounds like, whole brain radiation therapy, maybe 4 months. And about half of the patients died from their so-called systemic disease, extracranial disease, and half from intracranial progression of disease. So very bad situation within my professional lifetime. This began to change about 30 years ago. Roy Patrol is a neuro-oncologist, and he did this study while he was at the University of Tennessee. We referred to Tennessee earlier, but there you go, as another shout out. And this was the beginning of the focal treatment of metastatic brain tumors. So what this study showed, and it was a prospective randomized clinical trial, the gold standard of clinical research, it showed that if you added surgery to whole brain radiation therapy to somebody with a single metastatic brain tumor, that their survival would be longer, 40 weeks versus 15 weeks. So let's say 10 months versus 3 to 4 months. Now you might say 10 months is still not great, but it's measurably longer. And it's better if you do it at the beginning than at the time of the tumor growing back. So this was the first established proof that surgery, meaning a focal treatment, was of benefit for patients with a metastatic tumor. So the rationale for surgery is to debulk the size of the metastatic tumor, so-called cytoreduction, to confirm the diagnosis if there isn't one already, reduce mass effect or pressure on the brain, allow other therapies to work better, to reduce seizures if the patient is having any. But this is all dependent on various factors. What's the medical status of the patient? Can they withstand surgery? Is the tumor in a safe enough location for them to have the surgery? What is the type of tumor? Will it respond well or less well to medical therapy? And has the patient had prior surgery in that area and or prior radiation? So here's an example of someone who had and needed surgical resection of metastatic tumor. Oh, I guess the video didn't play, sorry about that. Okay, anyway. So it was a 72-year-old woman with known lung cancer who about a year later developed headache and vision loss of vision in what's called her left visual field. There's a tumor in her right occipital lobe. The right occipital lobe sees the left part of the world, so she had vision loss over there. And let's see, oh, maybe this will play now. No, okay, anyway. The point of the video is to show a demonstration of how a metastatic tumor may be below the surface of the brain, but it's still separate from the brain. So it lends itself to a complete removal. And this photo shows how the tumor is walled off by these cotton strips. And this is the hole when the tumor was out. So this tumor has not grown back. But now, 16 months later, the patient has a new tumor on the other side. Now what? It's pretty small. On the other hand, she also still has a visual loss from this tumor over here. Can't really see well to the left. Now, if we do surgery here, she may lose her vision to the right, that she'll be blind, in other words. What do we do? Does she need surgery for that? So the point of this study by the same neuro-oncologist, Roy Patrol, 8 years after the prior study, 1998 versus 1990, was to show that some kind of radiation was needed after surgical resection of a metastatic tumor. The first study showed that surgery was better than just whole brain radiation therapy alone. This study showed you need some kind of radiation after surgery, because without that, the risk of the tumor growing back was very high, 3 times as high. Observation versus whole brain radiation. The question is, though, is whole brain radiation the best way to give radiation to these patients? And the answer is, just to give you the punchline, is no. The answer is that the best way to do it is what's called stereotactic radiosurgery, or SRS. And this was defined by this brilliant pioneering neurosurgeon, Lars Leksell, in Stockholm, Sweden, in 1951, 69 years ago. he coined the concept of stereotactic radiosurgery, and he defined it as closed skull destruction of a precisely defined intracranial target using ionizing radiation. So when people hear about this treatment, even today, they say, oh, it's so high tech. And I suppose it is, but it's a 69-year-old concept. It's much older than the whole history of neurosurgery, than half of the history of neurosurgery, which is 115 years old. It was defined in 1905 as a separate field by Harvey Cushing. That's a whole nother story. So Lexell came up with the idea of radiosurgery, and he tinkered with different ways of how to deliver highly focused radiation. And ultimately, he came up with a device called the gamma knife. But this diagram from a paper in 1994 shows the physical concept of why radiosurgery is better for small targets than radiation therapy. Because if you give, let's say, a dose of what's called 20 gray, gray is a standard unit of treatment in radiation therapy. So if you give that as radiosurgery, as a single treatment, that's as much as 50 gray for someone with a highly malignant tumor, and as much as 100 gray for somebody with a less malignant tumor. So you get a big bang for your buck when you give radiation in a single dose. You can only do it to small targets though, because otherwise it's dangerous. When you have those small targets, it's very effective. So SRS is indeed a focal treatment. And just like that first Patchell paper showed, focal treatments are good and appropriate for patients with metastatic tumors. So compared to whole brain radiation therapy, when we use SRS, we treat only the tumors. Even someone like this who's got all these multiple tumors scattered throughout their brain. And if you look on the axial, coronal, sagittal images here, you see the treatment plans going only to the tumor and not to the surrounding normal functioning brain. So this is an accumulation of various studies which show that yes, if you add whole brain radiation therapy to radiosurgery, you do improve the local control, the chance that the tumor that you're treating will not grow back, but you do so at a cost to the patient's ability to think, to their cognition. And these studies used cognitive tests. This was the one that studied it most rigorously and showed that if you added whole brain radiation therapy, there was more than double the likelihood that the patient's cognitive abilities would decline. And this should not be a surprise because whole brain radiation therapy is what it sounds like. It's radiation to the whole brain. Now that radiation may kill tumor cells more than it kills normal brain cells, but it does have an effect on the normal functioning brain cells. And this study, which was published just 2 years ago, compared giving radiosurgery alone or radiosurgery plus whole brain radiation to look at the patient quality of life. And what this showed and proved as a prospective randomized clinical trial was that the tumor control was similar whether you added whole brain radiation therapy or not, but the quality of life was much better in the patients who had SRS alone. And interestingly, although this was not statistically significant, it approached significance, overall survival was higher in the patients who did not get whole brain radiation therapy. If they got radiosurgery alone, they lived an extra 3 months. And that probably reflects the quality of life decline that resulted from the addition of whole brain radiation therapy. Now you're probably thinking, wow, 10 months versus 7 months, I mean, who cares? But this does not reflect the current state of patients with metastatic tumors, and you'll see that later on. So what are the indications for SRS for patients with metastatic tumors? We want to obliterate the tumors. We don't want the tumors to grow slowly. We want to stop it in their tracks, but the tumors have to be less than a certain size so we could do it safely and effectively. And by the same token, they cannot be too close to a critical structure. And the example par excellence is the optic chiasm. The tumor's too close to the optic chiasm, you have the risk of blinding the patient if you give them a therapeutic dose of radiation in a single dose or a single fraction, as it's called. So these are 20-year-old, 25-even-year-old guidelines for SRS for metastatic tumors. and they remain in effect now. So the device that we use here at Northwell Health for radiosurgery is the Gamma Knife. This was the device that Lars Leksell, who invented the concept of radiosurgery, went on to invent, and the first Gamma Knife came online at Stockholm in 1968, 52 years ago. And it's gone through multiple iterations and technical improvements since then. We're on the 6th generation of the device now. And this is the device in which there's the most literature about metastatic tumor treatment and about everything else in radiosurgery, which is not to say that you cannot do SRS with other devices, but there are some unique advantages to doing so with the Gamma Knife. And how does it work? It's a deceptively simple concept. The Gamma Knife helmet, which is inside the device here, has 192 radioactive sources. It's from an artificially produced radioisotope called cobalt-60. And these sources are arrayed in such a way as to aim towards what's called the isocenter. And each separate source gives a very small amount of radiation as it passes through the scalp, the skull, and the brain. But where they meet, and it's purely an additive function, where they meet, those radiation beams add up to a very potent amount of radiation to the target. Again, that's what's called the isocenter. That's a photo of what the Gamma Knife looks like. It has an onboard CT scan, which is contained in this side arm, which helps to make sure the patient's in the proper position during treatment. And there are two technical ways of doing radiosurgery. We could do it with a Gamma Knife frame, which is attached to the patient's skull as, well, you see it through the scalp, but it goes partway through the skull. This was the original way that radiosurgery was done going back to the 1960s and really until just a few years ago. And there are some benefits for doing this. All the planning, all the activities done wheels in to wheels out, as my colleagues at the University of Pittsburgh like to call it. The frame is put on, the patient is imaged, the treatment is planned, the treatment is delivered, the frame is taken off, the patient goes home. However, some patients find the frame application painful, and if you want to give the treatment in more than one fraction or more than one dose, then the frame is not really an option. So with this new generation device, the Gamma Knife Icon, as it's called, we can use a mask to do SRS. So we can treat patients with one fraction or up to 5 fractions, which is what SRS is. It's any treatment of a target with a highly focused amount of radiation in up to 5 fractions. And this is completely non-invasive, and you bypass the pain of the frame application. So how can we use SRS for patients with metastatic tumors? And most commonly, we use it as the primary treatment and the only treatment that they need for their individual tumors. And the results can be great. So this patient was at the time a 59-year-old woman, and her presenting symptom was numbness in her right hand, and it was because of this tumor in her left parietal lobe. So she was treated with 18 gray. Again, gray is the dose for radiation of any kind, whether it's SRS or radiation therapy, in a single fraction. Then she had a lung tumor removed by thoracic surgeons. She got chemotherapy, and this was a redundant. It was the primary tumor that was removed with, not her brain tumor. For that, she only had the radiosurgery. So 10 months later, the tumor looks a little hollowed out, although the outside of it hasn't come down. She does have some more edema for which she was treated with steroids, but okay, we waited. We got what's called MR spectroscopy, which shows that there is a peak of what's called lactate, not lipids, lactate within the tumor consistent with radiation necrosis or cell death. And by waiting, we allowed the tumor to shrink down on itself. And now 10 years after her treatment, she has no evidence of disease in her brain or in her body. This is the result. This is what her left chest looks like after She had the tumor and part of her lung removed, but she's working as a physician. She's a rheumatologist. She's 69 now, so she's working 3 days a week, not 5 days a week, but she seems to be effectively cured of her cancer, including her metastatic brain tumor. But sometimes patients still need their tumors removed for the reasons that I gave above. So this patient was 62 years old when nearly 7 years ago, Merry Christmas, she came in with a receptive aphasia, meaning that although she was able to speak fluently, she had trouble understanding and her words didn't make sense. And it was a little bit amusing in our case because she's by nature a talkative person. So she was just going on and on, talking all kinds of nonsense. You can make out the words, but together they didn't really mean anything. And it was because of this tumor here affecting her language function, her being language dominant in her left hemisphere, as most right-handed people are. She had had melanoma removed from her back 3 years earlier. It was thought to be a cure, but alas, that was not the case. So she had a craniotomy and then resection of that tumor. 6 weeks later, she had gamma knife radiosurgery to treat the area where the tumor had been, and a separate and asymptomatic tumor in her medial left parietal lobe. Following that, she received a 1-year course of immune therapy with ipilimumab, which is known commercially as Yervoy. And now, 6.5 years later, she's got a little scar left over from the SRS where the surgery and the SRS was given, but she is neurologically intact. You can see the left parietal tumor has disappeared and she has no systemic disease. So we're optimistic that she is cured. And specifically in the case of melanoma, 10 years ago or so, if you had melanoma to the brain, there was no effective treatment for that. It was practically a death sentence. We would give whole brain radiation therapy, try chemotherapy, but it almost never did anything but prolong survival a little bit, with a lot of morbidity to the patient, lots of side effects. And now the side effects in her case of the immune therapy were none. The side effects of the gamma knife really were none. And she's going about living her life now, age, I guess, 75 or so. So if you go back not that long ago, 12 years ago, this was an algorithm for treating patients with a single or several metastatic brain tumors. If their disease in their body was uncontrolled, you might give them whole brain radiation. If they had controlled disease in their body, some combination of surgery, whole brain, radiosurgery, blah, 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 blah. Forget about it, as we say in New York, for those of you elsewhere in the US and around the world. Now, the treatment is SRS. Stereotactic radiosurgery is unquestionably the treatment of choice for the great majority of patients with metastatic tumors. And that includes people with many tumors, not just a few tumors, let alone not just one. So this is the picture that you saw earlier, picture of the patient you saw earlier. It looks like multiple gumdrops in the head. Of course, these are just tumors modeled in a gamma knife plan. And this is an example of what happens when you treat someone even with dozens of tumors. You treat them individually, and then you re-image them at some appropriate time later on, and the tumors either have disappeared or they've significantly shrunken. This patient had a new tumor here, and that required a new gamma knife treatment, but that's okay. It proved its efficacy in their case. So there are still people in neurosurgery and in radiation oncology who are skeptical about treating patients with large numbers of metastatic tumors. But this paper from Japan showed in a prospectively gathered, retrospectively analyzed fashion that even treating patients with many tumors, more than 10 tumors, even dozens of tumors, the control rate was comparable to treating patients with fewer than 10 tumors. So there's really no reason not to treat patients even with many metastatic tumors with SRS, and as long as you can, spare them the side effects of whole brain radiation therapy. We did our own study here at Northwell looking at patients with more than 10 metastatic tumors, and what we found was that if you kept the dose of the brain that got 12 gray of radiation to under 20 cc's, then the survival rate of the patient was considerably higher. That the 50% survival was out closer to 20 months rather than 13 months. And at 3 years, there were 20% rather than none of the patients were alive. That there are other factors that could be at play here, but it does suggest that an important consideration is to keep the volume of normal brain getting radiation during SRS as low as possible. And that's why having devices that give the radiation and as focal a way as possible is very important. Now, if you're going to be treating patients with metastatic tumors as a neurosurgeon, you have to know the new world of targeted and immune therapies. So the first family that came out, the targeted therapies, were a variety of what are called tyrosine kinase inhibitors that are aimed at tumors that express specific antigens that indicate a sensitivity to those inhibitors. And those were first used in patients with lung cancer and in melanoma. And following in their wake were the immune checkpoint inhibitors. And you probably have seen ads for these in publications online or in print. You may have seen TV ads for them, TV commercials or online ads and so on. And in fact, last year's Nobel Prize in Medicine was awarded to two investigators from MD Anderson Cancer Center in Houston, who were really just looking at the immune mechanism in humans, and they came upon the idea that you could unleash the immune system to attack these tumors by inhibiting certain key antigens that are used by cancer cells to block off the immune system. And it's not propaganda or advertising baloney. The effect of these treatments alone or in combination patients are dramatic. And in fact, some of them even get in to treat tumors in the brain. They cross what is known as the blood-brain barrier, which I imagine you've heard about. So this was a study that we published together with colleagues at Yale and Journal of Neurosurgery 8 years ago, and it showed what a huge difference adding ipilimumab alone to patients with melanoma specifically did for patients with metastatic brain tumor. Huge increase in the likelihood of survival up to 2.5 years after treatment, and some increase even 3.5 years later. And you saw that example of the patient I gave you earlier, someone who is 6.5 years out and appears to be effectively cured, and that's not something that unusual to see nowadays. Now here's kind of a wacky idea that was proposed by my colleague Tony Asher, who's in Charlotte, North Carolina, and he came up with this about 8 years ago, and everyone thought he was crazy. Why would you give radiosurgery before taking a tumor out with surgery? It makes no sense. Take out the tumor, then you give the radiation. And he said, no, no, no. By doing it in advance, you will have a better defined target, not the ill-defined target that we see on MRI after surgery, and you'll decrease the risk that tumor cells will spill and be viable and form islands of malignant tumor around the area of surgery, what's called leptomeningeal disease in the membrane of the brain that is very difficult to treat. And it turns out in this later study, this is not his first study, this was a multi-institutional retrospective study, the risk of leptomeningeal disease, that's in this box here, and of radiation necrosis as well, is much less if you give the radiosurgery before surgery than if you give it after. And this is a treatment modality that neurosurgeons should be encouraged to adopt. So here's what it looked like in practice. 71-year-old right-handed man who developed lung cancer a year earlier and had various treatments, but now he had headache and ataxia, meaning decreased balance, kind of thing that's usually caused by a problem in the cerebellum. And Lo and behold, he had a large cystic tumor in his right cerebellar hemisphere. And I thought he was a perfect candidate to treat him with gamma knife radiosurgery before surgery, especially with a cystic tumor. It's got a lot of fluid with cells that could spill out and spread everywhere and cause malignant deposits around the brain. So we gave him a full dose of radiosurgery the day before the surgery, 20 gray. At surgery, only a day later, the tumor already looks a little different than it would if we hadn't given it radiosurgery. You can't really tell in this picture, but trust me, it was firm, it was less bloody, kind of gray colored. This is the MRI shortly after the surgery, and this is the follow-up MRI on pembrolizumab. That's the brand name is Keytruda, 18 months after. So no leptomeningeal disease, no recurrence, and that's a good example of the concept of treating somebody with preoperative radiosurgery. Now look, nothing we do is 100%, and that's true of SRS as well. And sometimes the tumors do grow back after gamma knife radiosurgery. So then what? Can we repeat the SRS? Sometimes we can, excuse me, but as in this person's case, doing so would have meant treating a large target in a sensitive area of the brain. He's already getting some receptive language deficit. Again, he's right-handed. This is in his left hemisphere. No surprise that this is his dominant hemisphere for language. So he had awake surgery so we could monitor his language function while we're taking out the metastatic tumor. This is the OR setup. Here's the anesthesiologist taking pictures of the patient who will get his revenge later. The neuropsychologist here. And will this play?
At the end of all of these, I want you to tell me the word that would fit to complete it. Okay, so try this one. Not only read the sentence, but fill in the word that's missing. Good, okay. It was just not me explaining it too well situation.
So that's my friend, neuropsychologist, Dr. Ken Perrine, who is testing him. And while he's doing that, I am stimulating the surface of the brain to see where there are areas of speech arrest. If you stimulate and the patient stops talking, that means that is not an area that is safe to
at the end of
with surgery. And you can see here, these are numbered tickets, as they're called, that show areas of great language sensitivity and that define this area where it's safe to enter to the brain. So that's where the cortical opening was made to take out the tumor. And afterwards, the patient moves himself off the operative table onto the stretcher, and in the recovery room, he gets his revenge. Now he gets to take pictures of everyone else with a camera. There are other ways of dealing surgically with patients whose tumors regrow after SRS. And one of them that is somewhat newer, although getting a little bit antique now, first reported 12 years ago, is laser interstitial thermal therapy, or LIT for short. And you could see this was reported by a French neurosurgeon in Paris 12 years ago. And it's a very interesting technical application to treat patients with metastatic tumors. As its name says, it's thermal, it's heat. You are destroying the tumors with heat. And what is unique about this treatment and what made it a practical reality is the ability to monitor temperature changes in the brain with MRI. Because there are other ways of putting heat into the brain. You could do it with a radio frequency probe by which passes an electrical current through the probe. You could do it with microwave fibers. This was done decades ago. It could be done with high intensity focused ultrasound, which can be applied to some areas of the brain, but not all. And lastly, with laser energy, which is indeed compatible with an MRI. So even though LIT was first described to treat patients with brain tumors in the mid-90s and to treat liver tumors 37 years ago, what it lacked was a way of monitoring the effect of the treatment as was being done. But that's That is what's different about contemporary lit. So the device that we use at North Shore University Hospital is called Visual Ace, made by Mentrotic. And it uses, as you see, a 980 nanometer saline cooled laser, and you can create very sharply defined lesions with this technology. So if you treat a lesion with radio frequency heating or with cryosurgery by freezing something, you get this transition zone between the target and the area that you want to spare that's as much as a centimeter wide. But with lit, that transition zone is usually less than a millimeter. So the surrounding brain is spared the effects of the lit much more effectively. The lit is done in MRI. The laser fibers are placed in the OR, but the lit itself is done in the MRI. The computer with the laser talks, in a sense, to the MRI. The laser fiber goes from the computer through a panel in the wall to the patient, who's now in the MRI. You get data back from the MRI, and similarly, saline is used to cool the laser so it doesn't char and overheat as it's delivering the heat to the target. So this is an example of somebody with a difficult tumor to treat. She actually had whole brain radiation therapy and radiosurgery to these multiple metastatic brain tumors, but now she's developing a tumor in her pons that is not safely surgically accessible, certainly not in somebody with metastatic breast cancer. She's starting to get some weakness on her right side, and she's getting some imbalance, but with all that, she has a performance status of 90. This stands for Karnofsky performance status, meaning that she can work. She's got some deficit, but is still completely independently functioning. And this is a GIF that shows what the lit looks like. On the left, you see the actual thermometry, and this is what you see on the MRI screen. You could see the temperature change as it happens. And this is the so-called damage estimate that shows where the cells are being killed by the laser heat. And this is done by a combination of the heat and the time that the laser is in. So you see what's happening when you're doing it. So her ataxia was a bit worse after surgery, but it resolved after a month. You could see the edema is somewhat worse, but then resolves, and there's a little hollow shadow where the tumor was a month after the treatment. So, in conclusion, I hope you could see and believe that current and future targeted therapies and immune therapies will yield greater survival for patients with brain metastases. And this may allow for lower doses of SRS and improve survival, and maybe avoiding all kinds of radiation as a result. So we have to consider the impact of these therapies as we deal with patients who will be living longer with metastatic cancer, and as we consider applying different surgical therapies for them. So over the last 60 years, the treatment of patients with metastatic tumors has evolved from nothing to whole brain radiation therapy, to adding steroids, to surgery plus whole brain radiation therapy, to whole brain radiation therapy and SRS, to SRS first, then whole brain radiation therapy, then SRS only as the treatment of choice. And that controls metastatic brain tumors most of the time. Still, a small group of patients will have tumors that grow after SRS while maintaining good systemic disease control. And we do have, as you've seen, a variety of surgical methods to treat those patients and those tumors, and those should be offered. And there is no room for nihilism in the management of patients with brain metastases, because they can live a long time and even effectively be cured. And it's really a great thing to live through and be a part of the evolution of these treatments. So thank you for your attention.
I'm going to open up the chat right now if you want to take questions. Also, do you want to give your story a little bit?
All right. So as I said to Josh earlier, if anyone who's eavesdropping, my story is not especially interesting. But I entered medical school being interested in the brain, being interested in neuroscience and neurology. And probably about half of the people in neurosurgery come to the field from that end. They come to it from the neuro end, whereas the other half come to this from the surgery end. So I ended up liking surgery a lot as a third-year medical student, which I didn't anticipate doing. And then when I got to do an optional week of neurosurgery in my neuroscience third-year rotation, it really blew my mind. And I had an epiphany. I said, gee, you know, I'm in my third-year medical school. I could do this. And that was it. I really didn't look back from that. So after I trained, I joined the faculty of Rutgers, New Jersey Medical School. They had just started their residency program there. And I had a great gig there for 19 years. I came to Northwell 13 years ago to build an academic brain tumor program and also to develop an ACGME accredited neurosurgical residency program. And those things have, I dare say, have worked out pretty well. And my interests academically in terms of clinical research are related to radiosurgery. You've seen that, no surprise. Image-guided neurosurgery, including developing new techniques for intraoperative MRI, for brain surgery, primarily for brain tumor surgery, running clinical trials, for brain tumor patients. And I still have a hand to some extent in the world of stereotactic and functional neurosurgery, which is another interest of mine and dovetails with the idea of image-guided neurosurgery. So that is my story in a nutshell. Very much involved in organized neurosurgery, which is really exciting, something that I like to do. And whatever you all are going to do, if you're going to do it in medicine, any kind of medicine, I suggest you get involved in organized medicine because it keeps you stimulated, keeps you fresh. You get to meet colleagues from other institutions, whether it's around the country or around the world. And it's fun to do it. And even after decades, I still like doing that. Personally, I'd like to say I'm like a medieval peasant. I've always lived within 10 miles of my birthplace, which is in Brooklyn, for better or worse. I certainly think it's a good thing for people to get out and see the world. I lived 3 months in Boston when I did a fellowship in stereotactic neuro-oncology at the Brigham. That's the longest I've lived anywhere else. So yeah, my advice to you is to get out a little bit. Mr. Katz here at least spent 4 years in St. Louis, or 3.5, which is good for him. So that's my story. Like I said, I went straight through college, med school, training, and then career. No regrets, but I think it's good to be able to spread yourself out a little bit as well.
All right, I'm opening the chat up now, so the questions will come in pretty quickly. I would say just take the ones that you want to answer that you think are, yeah, you can you see the chat?
Whoa.
Yeah, if you scroll up, it stops like moving the chat for you. It won't keep moving it if you scroll.
Yeah, but I don't want to shortchange anybody at all. So.
Well, we have 1,600 people right now, so
I get it. At 16 minutes. So if I answer 100 questions per minute, I'll get to everybody. Do we treat children with gamma knife? The short answer is yes. Regarding metastases, it's rare, fortunately, for a child to have a metastatic tumor. So in that case, I'd say that would be a very rare phenomenon. Awake patients, it's amazing how people can tolerate that. If you prep them in advance and you position them the right way and you use your local anesthetic the way you should. And I always ask people, hey, how was that? They said, yeah, not bad. Would you do it again? I said, yeah, if I had to. That basically everybody says that, which is always a shock, pleasant surprise, but still a surprise to me. GBM, oh, now you're getting into a complicated topic, Sergio. SRS is by definition a highly focal treatment. GBM is by its nature a non-focal disease. Does that mean it never has any place? It does, and when someone has a small nodular focal recurrence, of their glioblastoma and they're otherwise in good shape, we do treat them, but we don't recommend routine treatment of glioblastoma patients with SRS. There have been studies that have looked at this. So it has a use, but it's a limited use. Speech, oh yeah, speech can vary greatly from one person to the next. So you got to be very careful about the speech areas when you're undertaking any kind of treatment, surgery or radiosurgery in that area. Could you over-radiate somebody during gamma knife? Oh, abso-friggin-lutely. If you don't do gamma knife correctly and safely, you can cause great harm to somebody. You have to make sure that your target is correct, that your volume is not too big, and that your radiation dose is not too high. The symptoms won't happen immediately, but they'll happen within most likely a few months. If you go really hog wild, it could be a few weeks, but let's say a few months, and they will get injury to their brain, like they had a stroke or other kinds of brain injuries. So you really have to know what you were doing. Why are these tumors more likely to form metastases? No one really knows the histological reason why that's the case. If we knew that there was a protein in a melanoma that made it metastasize and we could turn it off, then obviously that would be wonderful, because then the patients would not get those metastases and they wouldn't need everything else that goes along with that. And this, of course, is a subject of ongoing basic science, cancer biology. Demographics, it's a question of the tumor type. Advice for neurosurgical residency. That's a big topic that we could fill a couple of hours talking about that, and I don't know, maybe we should, but you got to do well in medical school. You need to show some interest in the field by doing some research. You need to do well on USMLE Step 2. Now that Step 1 is pass-fail, you're going to have to do well on Step 2. You're going to have to do well on your rotations, both in your home and your away institution. This year, there are no away rotations because of coronavirus, but that's going to change, I hope, next year. And these are all commonsensical things that I'm sure you would understand. You need to do awake surgery where you're going to resect the tumor in an area where language is at risk. You could test motor function, sensory function, visual function with somebody under general anesthesia. There are ways of doing that neurophysiologically, but language, no. Language, you need somebody to be awake. How do you tell the difference between healthy and tumor tissue during surgery? In the case of a metastatic tumor, with essentially no exceptions, you could just see it. Like those cases that I showed you demonstrate, the images I hope showed, you could see the border between the tumor and the brain. There are other ways of doing it, though. You could do intraoperative MRI, you could do intraoperative CT. In the case of glioblastoma, you may have heard about the use of a compound called 5-ALA, which makes the tumor show pink under blue fluorescent light. That's a whole different topic. So you're relying a lot on your surgical experience, but even if you have these other adjuncts, whether it's the 5-ALA or intraoperative MRI, you still got to use your noodle, and you can't just remove something because it shows up abnormal on the imaging. You have to know that what you're doing is safe. Is it common for your students to have a sense of direction? I think maybe 30% or 33%, like a third of the students know that. And believe me, you should not feel compelled to know what you're doing as a first-year medical student. I found the time to find my calling. Maybe you wrote that question before. Oh, no, I guess you did it after you heard my story. But yeah, you'll find it in time. Don't worry about that. Yes, there is increased freedom from progression and survival when you combine NIVO and IPI, but there are well-defined at this point, even though they change every 3 months or so, algorithms for treating patients with cancer with targeted and immune therapies. And if you're not doing this all the time, there's no way to keep it in your head. And I don't do that all the time, so I don't have it in my head. And it's worth looking up those algorithms to see how well thought out they are. It's just really it's just very interesting to see and good to see how there's science behind it and logic. So, well, thank you, Susan. Yes, you could do SRS elsewhere in the brain. You could certainly do it for the lung, for the liver, for the prostate, for the pancreas, anything that can be imaged and where there's a focal target. Now, in those parts of the body, the surgeons are not involved in the SRS in the same way that neurosurgeons are in the brain. And that's for a bunch of historical and clinical and personality of the specialty reasons, but they do exist, and it's a way to avoid either surgery or over radiating other areas of the brain. So how does Gamma Knife not target the other areas if you tumors in the middle of the brain? Well, India, it's the same thing no matter where your target is. As long as you put that target in the isocenter of the Gamma Knife where the beams intersect, the significant radiation only accumulates where those beams intersect. So if you have a 4 millimeter target and you select 4 millimeter holes in the Gamma Knife, what are called collimators, so that only 4 millimeter beams exit from the Gamma Knife, then we'll make roughly a 4 millimeter diameter sphere of radiation. And the physics of the Gamma Knife are such that the radiation falls off very quickly. It's not as if the area around that won't get any radiation at all, that it gets very little. So that once you get to be a millimeter or certainly 2 away from the target, a very tiny amount of radiation results. And that's why you don't lose hair, by the way, from a Gamma Knife treatment. So we did answer that already. So what are the risks? The risks are that, like I said earlier, if you don't do it the right way, if you give too much radiation, you can injure someone's brain. If you give too little, then your treatment's not effective, and then your tumor is going to continue to grow. And you may not consider that a risk, but it certainly is a risk. For SRS, you don't require surgery. Well, if it was you or your family member or someone that you knew, and you knew that you could get the tumor treated effectively by walking in the morning in your street clothes and you leave a few hours later, the treatment is done, no surgery, wouldn't you want that? There is some literature that suggests that there is a slight increased benefit of local tumor control if you add surgery to the Gamma Knife, but it's a small increase. And from my mind, it's not enough. So the answer is no, you do not need to do surgery to do SRS. The only question is, if you're doing surgery, do you do the SRS before or after? Like Dr. Asher has advocated, and from my mind has proved, it's better to do the SRS beforehand when that is technically possible. Do the tumors responsively based on their genetic? Well, the genetic difference has not been worked out. Histologically, to some extent, yes. So for radiation therapy, there are tumors that are radiosensitive and radioresistant, as they're called. So let's say breast and lung cancer are radiosensitive. Sarcomas, renal carcinomas, AKA kidney cancer, is radioresistant. But for Gamma Knife, because of the high concentration, the high dose, even the radioresistant tumors respond much better than they do to radiation therapy. Although, even within those groups, the radiosensitive tumors do respond better, somewhat better, slightly, to the SRS. CyberKnife and Gamma Knife, these are two devices of doing SRS. I have worked with both. I still have privileges at a CyberKnife facility. I think it's a perfectly good way of doing stereotactic radiosurgery. I prefer using the Gamma Knife for a variety of reasons, but you could certainly do it with a CyberKnife. Again, these are just two different commercially available and excellent devices, and both invented by neurosurgeons, I might add. The Gamma Knife by Lars Lexell and the CyberKnife by John Adler. Well, you know, if you want to do something before med school, and you could do research for a medical school faculty member, whether it's clinical or basic science, but if you're going to do that, it should be impactful. It should not just be some random kind of thing, and you need to think about it and pick the right kind of mentor to do it, so it will if your goal is to help you get into medical school, you want it to do that. What percentage of metastatic tumors on average are operable? Hey, everything is operable. The question is, do you want to? Is it safe to do it? Probably at least 60% of patients who come in could have the tumors operated on, but it doesn't mean that they should. They're much better served with SRS. So how do you decide? The patients who need surgery have a tumor that is too large to treat with SRS. It is surgically accessible and it's causing symptoms. Those are the indications for surgery. So those, look, I just did a surgery like that on Friday, 3 days ago. I wish I had the images in time to show you, but whatever, they all didn't get processed in time. So I'm not loath to do it, but again, I'm applying the golden rule. I'm doing unto others as I would have others do unto me. I would rather have, if it was me, the least invasive treatment possible for my family member and for myself. And that means if I could do SRS and avoid surgery, that's what I want to do. The laser, though, the laser only works at the tip. So you have the laser fiber goes through a sheath and the heat is generated only at the tip of the laser over like about a 3 millimeter length. And the heat it creates sort of like an oval around the tip. The oval can reach as much as about 2 centimeters wide and 3 centimeters long. Side effects we talked about. We talked about doing it in the future. Yes, so you could do radiosurgery outside of the brain, as we talked about. Well, tumors tend not to grow after Gamma knife. If you look at the literature, the failure rate that's quoted is as high as 20%, but in our experience here, it's more like maybe 5% at most. The tumors may look at first like they're growing after the SRS, but they're not growing in reality. How do you treat a patient awake without making them panic? You have to make sure when you talk to them that they're the kind of person who can tolerate it. If they insist that they cannot, and they just seem like a highly anxious person, then you're not doing them any favors by trying to do it awake. And in the end, you're going to have to do it under general anesthesia anyway. So you might as well know that in advance. But again, like what's surprising is how many people can actually tolerate it. But they do. The difference between Gamma knife, well, we kind of talked about that. Gamma knife is highly focused and given in 1 to 5 treatments. The radiation therapy is to large areas, could be the whole brain. It's given typically over weeks. If you want to go into neurosurgery and you're in college, you need to see some actual surgery. You should see some patients as outpatients so you get a sense of what it's like, what the rhythm of that is like. And you got to feel that there's nothing else you'd want to do because it's a lot of work. And there's a lot of great moments, and then there's some occasional rough moments, as you could very well imagine. So you have to find the ability to think about and treat people who've got problems affecting their brain. It's amazing to me just talking about it, thinking this is what I'm doing as a career. Still is amazing to me after decades that you have the ability to manipulate their brain in a way that's going to help them. It's an awesome responsibility and a privilege, but you have to feel like it's something that you really totally want to do. So you got to see surgery and you got to see outpatients. Now the Gamma knife is just a brand name of SRS. I talked about that. I saw a case that clicked the switch for me when I was a third-year medical student. That's why I went into neurosurgery. We talked about gliomas. We do treat patients with meningiomas at times and vestibular schwannomas and even pituitary tumors with SRS. That's a whole nother kind of topic. We talked about what are the indications. Good question. Can you do 1 or more pre-op SRS in a patient? The best thing is to do it once and operate on them right away. That way they don't have time to develop the side effects of radiation to a big volume. And by the same token, if you gave it over 3 or 5 sessions and lots of time is starting to pass, and they may start to get side effects, edema from the treatment. So it's an intriguing idea, but probably makes the most sense to do it in one time. Neurology versus neurosurgery. that's it. Do you want to do surgery or not? Well, because one is neurology and one is neurosurgery. There's lots of cool things to do in neurology. There's no question about that. And some of them are procedural and interventional. But most of the time, you're not going to be doing that. And but hey, neurology is great, and so is neurosurgery. And I'm seeing Mr. Katz, so it looks like our time is up.
Yes. Thank you so much for speaking, though.
Okay, my pleasure. Gee, if there's any way to moderate questions via, I don't know if you or anyone's accepting emails, but if you could send along any digestive questions to me, I'll do my best to answer them.
All right. Sounds good. Thank you.
Thanks, everybody.
Have a great day.
Bye.